My name is Tammy Mulm. I'm the Director of Education at PQA, and I will be your host for today's webinar. Our topic today is improving quality through health plan and pharmacy value-based partnerships. Before we get started with today's webinar, I'd like to walk you through a few housekeeping items. First, please submit your questions during the presentation through the Q&A feature at the bottom of your screen. We will answer as many of the questions as we can get to during the discussion portion of this webinar. Additionally, the webinar recording has started, and the slide deck, as well as the recording, will be available to all PQA members within about a week following this presentation. It will be in the Member Resources library of the PQA website. The recording will be posted to PQA's YouTube channel. Last, at the end of this, as you're signing out, please complete our survey. This is helpful for us to continue to develop webinar content that is useful for you as PQA members. And now it is my pleasure to introduce you to today's presenters. We are joined by Dr. Maaria Kheiri, Director of Pharmacy Quality Improvement at Centene Pharmacy Services, as well as Mr. Jeff DiGeronimo. He is the Vice President of Program Strategies and Client Success at RxAnte. Please welcome Maaria and Jeff. Thank you for being here, you guys. Maaria, I'm going to hand over slide control to you.
All right, thank you, Tammy. Good afternoon. Thank you for inviting us back to this encore presentation. Jeff and I are really excited to have this opportunity to share once again, especially with those of you who weren't able to attend in May. So today we're going to go over how we utilize pharmacy-based programs to really improve our patient outcomes. I'll go over our program design, and then Jeff is going to do a deeper dive into the evaluation and success of our impact and impact of our value-based program model. So let's dive in. I'm Maaria Kheiri, as Tammy just shared. I'm a pharmacist by training. I support leading quality initiatives that improve medication adherence and overall health outcomes at Centene. Centene is a leading managed care organization serving approximately 28 million members across the country, spanning from Medicaid, Medicare, and Marketplace plans. Our mission is to transform the health of our communities one person at a time. A key part of that mission is really involving and partnering with our local communities. And with that, we've built partnership with our local community pharmacies, knowing that these local providers are the front lines of providing care, and they play a critical role in medication adherence and health education. Through our community pharmacy engagement program, we're able to provide actionable data to help close gaps in care and ultimately improve our pharmacy quality measures. Today, I'll provide insight on how these partnerships are helping move beyond the traditional role in our traditional models and create measurable improvement. Also ensuring members receive the right care at the right time, right in their neighborhoods. So before I dive a little bit deeper into the program, I do want to take a moment to share a personal story. It's one that really reinforces why this work matters so much. Personal story about my dad. He's always been someone that took pride in being independent and self-sufficient. Recently, in the last year, he's had a series of healthcare complications, which led to surgeries and hospital stays. And when he was finally discharged, he came home with an upwards of 15 or more medications. So with that, over a short period of time, our lives looked very different as a family. My mom suddenly became the primary caregiver, and they were left to manage new conditions as well as being overwhelmed with the long list of medications. So at that time, I really did what any pharmacist's daughter would do, and I took matters into my own hands. I went online, I bought a heat sealer and a little pack of those pill baggies, and I started my own homemade med pack system. We sat down, ultimately organized his medications first, but really focused in on creating a simple routine. That alone, that single intervention made a huge difference. That simple routine not only helped him, but also helped both of my parents. It gave them more of self-control and confidence, knowing that the meds were organized and easier to manage and be able to take on time, which gave them a peace of mind as they were on the right path to improve quality of life. That experience specifically has stayed with me, and it's really one of the reasons that I'm so passionate about this program that we've begun and started partnering with our community pharmacies. They're uniquely positioned to connect with patients, build trust, and identify issues early, and step in right when they know that a patient may need it the most and provide that extra layer of personalized care that can truly change their lives. As patients navigate complexities in the healthcare world, there's no single provider that can do it alone. So achieving the best possible healthcare outcomes really requires that collaboration between the entire healthcare team. So here, really thinking of that patient-centric approach, ensuring that the primary care providers, the health plan, as well as community pharmacies are working together. And as we partner together, patients then really receive a cohesive, coordinated care model. We know that a challenge that pharmacies often face is lack of access to full healthcare picture. So critical data, resources, insight on past experiences that the patient may have had. So we've developed a streamlined model to equip our community pharmacy partners with data and resources to better support our high-risk members. As community pharmacy not only supports closing those gaps in care and helping with our adherence measures, it's also well positioned to close gaps in care in our healthcare system. They're able to provide that health access in primary care deserts where there may be underserved areas or there's not primary care physicians available. And we know that 90% of Americans live within 5 miles of a pharmacy. So I think in the last few years, what we've realized, even post-COVID, is the fact that people really seek that human connection. The value of human touch, understanding that face-to-face interaction is truly impactful. Being able to read that a member may not fully understand their drug regimen, or they may have concerns as we have that one-on-one conversation with patients. So we're all well aware that most people visit their pharmacy exponentially more than their doctor. And very recently, the National Center of Health Workforce Analysis predicts a shortage of over 65,000 PCPs by 2036. As this shortage in primary care providers continues to grow, it's increasingly important that we strengthen that coordination among the care teams that are helping provide support for our patients. So as we looked at the impact of community pharmacies, there's several areas of quality that they can really be collaborative in supporting. They have the clinical expertise to support members across adherence measures, medication optimization, and comprehensive disease management, such as A1C and controlling blood pressure type measures. This focus area helps provide increased opportunity for pharmacist-led care in the community setting, which has steadily gained traction over the past 2 decades, which is really evolving, and it's proving to be a sustainable care model. So in the next slide, I'm not going to go over all of the details here, but wanting to really highlight that in 2003, there was a landmark study, the Asheville Project. This was one of the first to show that community pharmacies can significantly improve clinical and economical outcomes for chronic disease management. We fast forward 20 years, studies have evaluated that value-based payment model in community pharmacies, and really it continues to show positive financial outcomes when pharmacists are aligned with a performance-based care model and being able to drive measurable outcomes. So this progression shows the growing recognition and infrastructure supporting pharmacist-driven care, making it not only sustainable, but essential to the future of value-based healthcare. So as we began really scoping our model for our program, we evaluated advantages and also took a look at anticipating some limitations that we may face. So thinking about the advantages, patient accessibility is definitely one of the key highlights, knowing that pharmacies are frequently visited and that enables timely interventions, but also convenient locations and extended hours improve that access to care as well. The integration within community health, this is one piece that helps us explore additional potential where we can think of preventative services like screenings and immunizations, and also enhanced healthcare access. Knowing that pharmacists are really the experts in medication management. So a model like this focuses and hones in on pharmacists practicing at the height of their license, being able to simplify medication regimens and helping patients navigate their chronic conditions. And with that, knowing that one big plus is the community pharmacies may already have a lot of the systems in place. They are already helping to support some of the members when we think of the patient experience that they've set forth with a multi-pronged approach where they outreach in different ways, whether it's digital communication, telephonic, or face-to-face. They may have modes of communication to help med sync them or tailored medication packaging, as well as some focused medication counseling. So a lot of those systems vary across the board with different pharmacies. Some of the limitations that we anticipated, and we wanted to come up with ways that we could get creative to overcome these limitations were, first off, billing complexities. A lot of things that we would need to consider when it comes to some of those regulatory factors. Along with that, thinking of resource constraints. So we'll touch on this a little bit later, but thinking of staffing and technological limitations as well. And then with that technological limitations, thinking of the data integration. So we can see that pharmacy and medical data, a lot of times it remains pretty siloed. There's minimal pharmacy and health plan two-way communication, and our goal was to reduce that and come up with collaborative opportunities to have that visibility in patient care. And we really wanted to focus in on those patients that are at risk of non-adherence and showcasing different key elements of patient behavior to pharmacies. So as we worked on overcoming some of the limitations, there's also several options in developing the value-based care model. So as we began collaborating with pharmacies, we quickly realized that it would not be a one-size-fits-all solution. Customization was really key on our part, ensuring that we could create a program and tailor the program model dependent on the pharmacy type and their needs. So different categories when it comes to large national chains versus grocers versus independents, and we had to think about what type of customization or flexibility was needed there. So whether you start thinking about population level, member level, or down to the measure level targeting, we wanted to ensure that the program was built to incentivize and unlock performance-based revenue and the value-based model. So a quick overview of our program model, it really begins with analyzing member behavior. So really understanding challenges that specific populations face. We developed a target focus to help those members who are at risk of non-adherence, and they're really the ones that require the most support. Next, we partnered with the local pharmacies to really meet the members where they're at. Pharmacies are able to support with their unique personal connection and impact on local communities to deliver that personalized care. A key component was also being able to share with the local pharmacies actionable data. Along with actionable data, also thinking of what are the clear goals, and we align on specific goals so that we're successful as a group. And then metrics to metrics that would be helpful to those local pharmacies so that they can easily integrate into the day-to-day workflow. And last but not least, activate that new revenue generating opportunity for local pharmacies. So on this next slide, there's two member journeys illustrated here. With the two member journeys, this illustrates medication adherence behavior without any program intervention. So the graph above showcases each patient's portions of days covered. So PDC over time based on their fill history showed below the graph. Both members here, member A and member B, they fill their first fill in February, and member A is naturally adherent. You can see that they're missing a few days in between refills, but by year end, they're adherent in that specific measure. In contrast, member B has inconsistent fill patterns and ends up becoming non-adherent. So our community pharmacy program is designed to identify members as in member B. So member B is really one that we can identify based off of their fill behavior is really at risk of non-adherence. So the next slide is going to showcase member B being enrolled in our program. So this program is not prescriptive or specific, giving specific actions to pharmacists, but rather notifies them of members who would benefit from additional support. Each pharmacy can then apply their own tools and strategies to help improve adherence tailored to those members' needs. So in this example, you can see in some of the graphics below, the pharmacy uses a variety of different support methods. So whether it's face-to-face counseling, telephonic or digital reminders, they have a lot of key touch points throughout the year. So for example, one of the early telephonic outreaches may have uncovered a barrier during their discussion, revealing that frequent pharmacy visits were a challenge for that member. That's where you can see in this graph, they converted the member to an extended day supply. Periodic check-ins then helped the member remain on track, but the key here is really early and often touch points throughout the year. So reflecting back on 2024, this slide really showcases some of those key learnings. Successful implementation of the community pharmacy-driven adherence program involves several key stages before seeing overall impact or lift. So that graphic on the left, I'm going to walk through each tile there. First, the pharmacies must be recruited or onboarded. So to participate in the program, there's some level of activity. Once they're onboarded, pharmacies need to actively deploy or essentially outreach and work the targeted opportunities that are provided to them. From there, we measure outreach, which is essentially successful outreach to members where they're able to reach the member, connect with the member, and relay the message. And finally, of those that were successfully outreached, only a portion of those members are going to have some type of behavioral change. And those are the members that are really going to have that impact on improving their adherence due to the intervention, and that drives the overall program lift. A major limitation at the program's baseline is pharmacy recruitment. So one thing that we could see and throughout the learnings in 2024 was if you build it, they may not come. So with that, pharmacists really can't participate if they don't know about the program. That was a big factor that we uncovered pretty early. As we knew that pharmacies may need additional socialization to increase awareness, we leveraged different engagement strategies such as virtual meetings, attending conferences, and having direct pharmacy visits as well. These efforts boosted the pharmacy recruitment from 28% to 80% in 2024. So even with the high recruitment, we can see here on the graph on the right that our overall deployment opportunities really stabilize around 45%. So some of the common limitations as we met with pharmacies that were brought to our attention were opportunities such as really understanding staffing constraints, space and overall physical space limitations, and then also interesting feedback really depending on the pharmacy type. So again, large chains versus independents versus grocers and their workflows and their flexibilities, all of that really showcases why it's not a one type of solution fits all. So there's varying levels of program understanding as well, and that's where we want to ensure that there's program understanding at the store level, and the socialization and building those partnerships with pharmacies is so important. So we continue to collaborate with pharmacies to identify and reduce these barriers and overcome these challenges to ensure that we're able to improve the program deployment, which would ultimately help support members gain members to overall become adherent. So within this last slide, I'm going to give just a quick overview and recap what the program findings and the model that we've created. Key to success was really understanding that early and frequent engagement with members is one of our focus areas. Also, having in-depth conversations. So understanding underlying barriers that may not be medication related, but it's impacting their medication regimen or being able to pick up their medications in general. Those conversations are so important to really understand what a member may be facing. And of course, having a strong targeted analytics strategy. So identifying which members really need that support. With that, I'm going to transition it over to Jeff. He's going to be able to provide a little bit more in regards to our analytic strategy and some of the 2024 outcomes.
Awesome. Thank you, Maaria. So the strong analytic targeting. So that's where RxAnte got involved. We were primarily partnered with Centene on these two value-based programs for two components, or maybe even three. So really, we got brought in for the strategic analytic targeting and evaluation of the pharmacy incentive program that Maaria spoke to, in addition to our value-based program with the Mosaic Pharmacy Service that RxAnte launched about 5 years ago. That's our tech-enabled high-touch pharmacy service. Overall, there's a couple highlights about RxAnte to get us kicked off. We're a pharmacy care management company leveraging patent analytics to improve quality, reduce cost of care, and transform the patient's experience in the pharmacy setting. We were founded in 2011. A couple highlights around locations. Our technical headquarters and analytic headquarters are based out of Portland, Maine. And our clinical headquarters with Mosaic Pharmacy out of the Washington, D.C. area. We are a remote workforce. We support over 250 employees today. There are open positions, a couple patents as well. We manage around 31 million lives today across a range of lines of business that include commercial, Medicare, Medicaid, as well as exchange. We had really strong adherence improvements in the 24 calendar year as well as 23. So the published 23 data did support that RxAnte clients had 6 times the adherence improvement compared to the industry average. So again, continue to see some strong improvements for our client base. The annualized PMPY savings you see here highlighted is our initial Mosaic pilot we ran with a partner health plan. So a really strong total cost of care savings numbers, and then our net promoter score of our Mosaic Pharmacy Service, which I'll later get into in terms of how that compares to maybe a retail pharmacy setting. And as I mentioned, Centene, I want to thank Centene for giving us this opportunity on this project, and really started to highlight high-risk targeting for different value-based care models. When we have been part of value-based care models, it's really been focused on a range of things that you can set as your targeted outcome of interest. The two that we'll talk about today were primarily focused around these top 2 bullets. So adherence improvement, which was really the focus of the pharmacy incentive program, and then reduction in total cost of care and patient pharmacy service care management, which was the Mosaic value-based program we also ran in the 24 calendar year. We've also been part of more simplified value-based arrangements where it wasn't it was a little less outcome-based and more documentation-based. So that's where it was referrals to care management and documentation of barriers related to pharmacy issues. So we've been part of a range of value-based care arrangements. And then on the right is just a spectrum of things we feel like are part of effective pharmacy care management when actually interacting with patients. I don't think anything over there on the right super, I think, different across people's perspectives on what true pharmacy care management would include. I think the big component we started to jump into is that probably that top SDOH screening, which is a little more new in the last couple of years as CMS has pushed a few more new quality measures tied to improvements in certain at-risk populations. Now, when we get into the two programs we had developed with Centene, as I'd mentioned, there were two programs centered around total cost of care savings, which was the Mosaic value-based care service. That's that very high top of the pyramid bucket. We use two primary models to drive these two programs, and starting with Mosaic, we do have patented analytics around estimating the total cost of care savings attributable to adherence improvement for a given patient. We call that our value of future adherence score. That was our anchor, or really our stratification tool for delivering selection or targeted outreach for a subset of MAPD members. So again, a high risk group that approximately represented 10 to 15% of an MAPD POCA business. It does include over half the non-adherent members in a given population. And these patients, through our analytic and stratification tools, do, and we'll get into some descriptive stats in the next slide, do suggest that these patients have over 2x the average medical and pharmacy costs compared to an average Medicare patient. And then the second program really being primary focused on adherence improvement. So again, changing the selection around total cost of care improvement or savings into more adherence specific improvements at the population level. For this program, we leveraged our patented RxAnte score. So RxAnte score representing the predicted probability of a patient being adherent at year end. So back to Maaria's storyline about retrospective patient fill behavior, actively trying to catch patients that we believe are at risk of non-adherence. The big benefit of, right, like we see a lot of people using retrospective PDC as sort of a targeting mechanism. And we found a lot of value in proactively identifying risk based on retrospective fill behavior. So again, proactively coming into a year, knowing which patients are most likely to have those intermediate fill behavior patterns in the current calendar year, and being proactive in sort of who we target when. So again, with this population being more adherence-based risk focused, you do end up getting a little less medically complex from a patient's average risk level from a total cost of care perspective. This slide is really gives you a good landscape of how those two targeting mechanisms can give you a different type of patient pool. So on the left side, we have a medically our community pharmacy program that Maaria spoke about. And then we also have on the right side our Mosaic Pharmacy Care Service value-based care program. Just to set up the slide, we're taking a look at some medical complexity indicators. So right off the bat, we included around 300,000 patients in our community pharmacy program. On the value-based care arrangement with Mosaic, we're sitting right around 4,000 patients today. You can see the average medication count, again, skewed towards higher medication counts on the right side with the Mosaic Pharmacy Service at 9 chronic medications on average, compared to the 6 on the community pharmacy-based program side. You do tend to see that there are high-risk members for non-adherence that are brand new to medications. And you do tend to see that lower medication counts do lead to lower adherence rates. So there is some correlation there. Average HCC risk scores, again, as I mentioned earlier, the Mosaic Pharmacy Service with the total cost of care being our primary outcome of interest. It does give us a targeted group that, from an HCC risk perspective, presented themselves at over 2 to 2.5x the average risk, compared to the pharmacy incentive program, giving us more of an average patient from a HCC risk level standpoint in the patient population or the program population. And where you really see some of those statistics play out are some of these unplanned care event statistics that come next. So just looking at inpatient stay admissions and ER visits and prior to enrollment in these programs. On the Mosaic side, nearly 25% or even 33% experience some form of an unplanned care event, either that being an ER event or an inpatient stay. Those numbers come down, 1 in 10, 1 in 5, if we're purely focused on the adherence side. So you can see, again, some of that risk selection playing out in what the selected groups look like. And then overall, you can see both sets of members are much lower in terms of adherence rates than our populations tend to be. So if these are all 1-star adherence populations, the pharmacy incentive sitting right around low 50s, while the Mosaic Pharmacy Care Service was mid 70s from a baseline adherence perspective. Again, both of these presenting as 1-star, with the community pharmacy program being a little more skewed towards lower adherence. Both programs, you can see, target at-risk and highly disadvantaged patient populations. So we do use area deprivation index to categorize the potential risk of SDOH characteristics for a patient. So we do see patients living in highly disadvantaged areas throughout the country, 72% versus 86% between the two programs, but on both sides, very, very at risk, with LIS low income subsidy rates hover just below 50 and above 50%, nearing 60% for the Mosaic Pharmacy Service. So again, high risk patients. And then we do call out some less than 65 statistics just to get at some proxies for disability. So again, 20 to 30% depending on the program. So again, as we work on the left side, using RxAnte scores to deliver a targeted outreach program, and on the right side, our value of future adherence stratification tools. I'm going to go into a little more detail about the pharmacy incentive program, or the community pharmacy program. Here are some just high-level outcome metrics that we did track on an ongoing basis alongside Centene. With no surprise, we do see that activity rating, and I'll do a little more explanation about activity rating, but essentially the more active a pharmacy is in participation, the higher the outcomes in terms of adherence improvement. So to set up the table on the left side, we did have 3 different pharmacy partners included in the program. As Maaria had kind of gone through the recruitment process, once we get them recruited into the program, recruitment being, they've established themselves in a tool, and we see some form of engagement within the tool. And then we get into, well, how active are they within the tool? And that's when we get into these activity ratings that we've developed. Activity ratings being what percent of the total opportunities that we put into the program were actively worked by the pharmacy. And when I say actively worked, we as part of the program, we were getting weekly extracts from the pharmacy care management tools that were supporting the programs. We'd get return data on which patients were intervened or attempted on which given dates. So we were able to associate what percentage of total opportunities that certain pharmacies actually deployed or gave some effort to in the program. You can see that by the different partners, there was some variability. Partner C being the most engaged, right? 100% deployment. We were seeing some form of attempt happening nearly on every opportunity. When we work over to the right side, now we're actually attributing what portion of patients are attributable to a pharmacy that have different range of deployment rates or activity ratings. So if I gave you an example, if we looked at the middle row, I could say that 9% of all my patients in partner B were attributed to a pharmacy that had highly active deployment. Highly active deployment being, hey, they were able, for 9% of all my program opportunities, they were in a pharmacy that deployed 75 to 100% of all those opportunities they were provided. So again, we're looking to shift a higher distribution of our program opportunities into higher activity ratings over time. And then on the right side, we start to associate how activity is then correlated to adherence improvement. And the way we measure adherence improvement at RxAnte is we're able to assess baseline risk of adherence, which is that far left prediction on the x-axis. That's, again, our baseline risk of a patient when we put them or inserted them into the community pharmacy program. Now you can see those numbers, again, hovering around those low 50 adherence rates. You can think about those as like our coin flip patients. They're on the verge of being a non-adherent or adherent, or highly likely to be non-adherent, to be able to create a cohort that has a 50% likelihood of being adherent. And as we define that group, we're going to measure that group of patient and patient opportunities against a group of non-recruited pharmacies, which are, again, like patients that we've given, they've met the same selection criteria as any other pharmacy, but we see no engagement on the pharmacy's behalf. So that becomes our reference or control group in the process of evaluation. That's that dark blue line. That becomes our comparison group. And what we start to measure is the change in that adherence rate from the baseline prediction to the year-end adherence rate we see at the end of 2024. And when we do the difference of those two things, again, what's the difference of a given cohort against that non-recruited at baseline, minus the difference at the year end between the non-recruited and a given cohort. And you can see the bottom table represents that movement in score, or that change in expected adherence rate between baseline and year end for the range of activity cohorts that were described on the table on the left. So I could say for any pharmacy that was part of our recruited cohort, we saw a 3.3% adherence improvement for patients that were associated with a recruited pharmacy. And as activity levels ratchet up for an active cohort, again, any group that falls between somewhat active and highly active, it was 4.1%. And then the next question becomes after that is really like, where do we start to see results separate in engagement? Because we want to give a sense to a pharmacy on like how much engagement will it take for us to achieve a positive adherence improvement story. And what we see in these bottom on the far right results is that for any pharmacy that was in this not active bucket, so again, not active being a pharmacy that has been recruited, but they worked less than 25% of all their opportunities. So if you were to only work 25% of your opportunities, we saw no effective change in your adherence improvement as a total cohort. As activity levels started to ratchet up, so again, moving from somewhat active, we're talking about, again, pharmacies that deployed anywhere between 49 and 25% of their opportunities. Now we're starting to see some positive engagement on adherence, but it's limited. It's 0.6%. As soon as we got over that threshold of, hey, what about 50 to 75%, this moderately active cohort, now we're seeing real results of 2.6% adherence improvement. And then the true or the best picture result being, hey, if we got a pharmacy truly engaged in the program and you've acted on 75 to 100% of the opportunities we provided you, we saw adherence improvement generate as upwards of 7.6% on average. Now, that storyline didn't always play out consistently. We definitely have players in the market that will look for the windfall payment. Windfall payment being, hey, right, I can tell you the cohort I'm going to put into the programs 50% likely to be adherent. Potentially, there's this windfall payment to achieve payment potentially if if they're just deploying records, but there's no real true conversation to engage a new refill, that they could potentially be getting paid out on 50% of those opportunities, because we can 50% of them are going to be adherent on their own. And so this is where we start to see just variation in which pharmacy chains were really driving lift improvement and which ones weren't. And yes, on the totality, activity rating was highly associated with adherence improvement, but there were buckets of pharmacies where I'm looking at, the range between 40 and 60%, where, we started to see you in this range of activity that we expected let's say above a 3% result, but not necessarily achieving that. That would be a storyline where, hey, we're seeing activity occur, but we're not seeing the type of activity deliver a result. And that might be the message we have to carry to that retail pharmacy chain, that, hey, we're seeing deployment, but the activity itself isn't resulting in a true change in behavior. Whereas on the left side, there were examples where, hey, we have low deployment rate, but for what you are deploying, we do see we do see impacts occurring on the deployed records. And that's what the lift adherence improvement y-axis represents. It's for those pharmacies where we did actually have associations to which actual stores were engaged. We saw improvement in adherence, but on the totality, their deployment rate was still only 10%. So the storyline there is more, hey, you're doing limited activity. It seems to be playing out for when you do it, but on a population level, we need higher deployment to really move the needle from an entire patient panel perspective for your pharmacy store. And then on the far right is really the congratulate storyline, where we're seeing really high deployment and well above average adherence improvement, numbers that verge, above 5%. Which is upper end or even exceeding what we tend to see on a live clinical call. We do find that in the pharmacy setting, specifically the retail setting, the effect numbers seem to be higher than they truly are higher than we see in other settings, whether it's coming out of a call center, a health plan call center, or an automated intervention. I think the one comparable intervention to pharmacy care settings would be provider setting. And then we're linking, the next slide is more, how does the pharmacy care management program or community pharmacy program relate to total adherence improvement at the population level? So to set this slide up, we call this our magnitude of improvement slide. It measures on the y-axis the percentage of your adherence population that's in a contract with a certain year-over-year improvement category. The red being less than 0%, meaning there's actually a portion of your population that is attributed to a contract that's declined in adherence from one year to the next. And then as we work up the color of gray to green, higher levels of year-over-year improvement, with the darkest green representing a contract measure that improved by 3% or more year over year. So at the time, since 24 calendar year benchmark data for the whole industry hasn't been published, it's right around the corner here in the next month and a half here. So for comparison's sake, on the left side, I'm starting with the diabetes measure on the x-axis. I could say in 2023, in the Medicare Advantage space, 52.9% of all members in the MAPD book was attributed to a contract that saw a decline in the diabetes measure in 2023. If you compare that to Centene in 2024, we're only seeing around 7%. And really the effect numbers start to go up dramatically on the Centene side, where roughly 70% of our book is in a contract measure that's improving in the diabetes measure year over year in 2024, compared to, basically 10% in the prior year. Now, yes, this comparison is a little more powerful once we have the 24 data, and we'll be making that comparison. But for the sake of having some comparison, we did pull on the industry benchmarks in 2023. Now, just to describe a couple of the bullet points on the left slide, with the effect numbers we did generate in the evaluation and the amount of exposure at the population level, again, the 35% selected for a pharmacy incentive program, that represents, for an entire measure, for a given measure, I can say I put 35% of the entire measure into the pharmacy incentive program. 24% of an entire measure was attributed to an active pharmacy. If you associate those numbers alongside our effect numbers, we estimate that it's upwards of a 1% population improvement that's adding to that histogram on the right. So we can say 1% of our average improvement we can attribute to the pharmacy incentive program. And again, really, really strong effect numbers when we talk about year-over-year improvement at the contract measure level for Centene in 2024. Now moving over to the Mosaic Pharmacy pilot. Again, just to reiterate some of these stats, the 4,000 medically complex patients, we're still sitting around that 4,000 in the value-based care arrangement. Again, 2x the high-risk HCC risk score, and specifically, again, targeting total cost of care savings with a high savings group and high risk group from an SGOH perspective. To go through some of the Mosaic Pharmacy Care Services, it does include this continuous data-driven pharmacy care management approach. Again, a set of predictive analytics that do deliver member stratification and identification. So again, our selection mechanism. As we get into we do have a referral program that's conducted with a range of outreach to, again, educate the member about the service and determine who's interested in joining Mosaic. As part of that, there's an education and enrollment process. We have a enrollment team that, again, reviews all prescriptions and prescribers and is able to do med reconciliation and basically a comprehensive medication review at the time of enrollment. That process is fostered by a tool we call therapeutic decision support. The advantage Mosaic has, given we're partnered with Centene, is that we're able to see a true picture of a patient's pharmacy care history, as well as daily updates on any changes to that patient prescribing or filling, more like. So again, we're getting daily claims updates from Centene that we're able to run therapeutic decision support on a daily basis. As part of that, there is a specialized Mosaic Pharmacy Care medication box that delivers. It is a dose packaging, so it allows us to package, kind of back to Maaria's storyline of automated pill packaging with specialized plastic dispensing. It comes on a roll, and essentially you can get a morning, afternoon, or evening dosing. And again, we're throwing away the pill box, allowing automated pill packaging services that come on a monthly basis with 30 days supply. As part of the therapeutic decision support tool, two things that we have worked into that's been a huge benefit for the service is a cost sharing estimation tool. So it does try to estimate true out-of-pocket spend for a patient, really give them insights into when they're crossing the line into different cost phases within their pharmacy benefit. And then the last thing on the far right, which has been a real separation tool for us, has been a daily surveillance tool. Really being able to develop a tool that on a daily basis is triggering high-risk events based on new fill behavior for a patient. So whether new high-risk medications have been filled, or we're seeing a patient fill at a pharmacy they haven't retrospectively filled at, like an inpatient setting, can deliver us insights into maybe a recent ER event or inpatient stay that we might not have otherwise identified. So those are a couple things included in the Mosaic Pharmacy Service. Here's a look at the Mosaic pill packaging box. Again, pre-sorted dose pouches. All the pouches are individually labeled with the date and time. Box has a large, easy to read label. You can see that on the right side here. And we do 30-day cycles. We have found that with the complexity of our patients, again, these patients on average are 9, 10 medications, chronic medications, that dispensing 90-day supply would introduce quite a bit of waste given some of the frequent changes to a patient's regimen. So we do feel like the 30-day cycle is a way to reduce waste, as well as gives us this monthly checkpoint that we do a mid-cycle review every month before a box comes out to see if any new prescriptions have been recommended by their doctors within the last 30 days. Couple comments on the bottom related to some of our patients or caregiver feedback there. And then to highlight some of the outcomes, we did see 5-star adherence as well as sub-D closure rates through our pilot period. Again, ranging from low 90s to mid 90s, depending on therapy area. So again, really strong performance. And even more telling was our net promoter score. I mentioned this early on. 85 was our net promoter score through our surveys, our patient surveys. On the left side, you can see what other retail pharmacy chains net promoter scores are. So a range of -72, with the largest chain representing at 8. So again, patients really being happy with the service and the level of care that they're getting through Mosaic. So just to highlight some conclusions on just the aims of a value-based program. Again, analytic targeting. I think it's probably one of the most important parts to a successful program is blanket approaches don't work. We need to know who's at risk and who can benefit from a service. It's the first way of delivering an effective program. We do find real value in how the value-based care arrangement is structured. So again, aligning value-based incentives to reward engagement with at-risk members and improve outcomes. So again, as the community pharmacy program was designed with Maaria and team, again, some levels of a reward for baseline engagement, but true upside being delivered through adherence and adherence improvement. And then a comprehensive value-based pharmacy care management program created dramatic improved outcomes for very, very medically complex and vulnerable patients. Again, these Mosaic patients are very high risk and vulnerable. So I think these patients need a service outside of the retail setting. And that's the conclusion. I want to, again, thank Maaria and Centene specifically for the opportunity to partner on these programs, and want to thank PQA for another opportunity to present. So thank you, Tammy.
Absolutely. Yeah. Thanks, Jeff and Maaria. Thanks for sharing this collaboration between Centene and RxAnte. We probably only have time for one, maybe 2 questions. So there were several, and I apologize that we're not going to be able to get to them all. So I will just pepper you guys with a couple right now. What documentation system is being used in order to collect all this data, especially within the pharmacy dispensing systems?
Yeah, I can help with that one. So this is where I had touched on that element of customization that needs to be considered. So we do work with pharmacies and understanding the pharmacy type and then what are their needs. So it's not one single system that's utilized. A lot of pharmacies will take our data. We may send a flat file, so essentially a target lead list, and then they incorporate it into their proprietary platform, making sure that there's still those specific requirements, but it doesn't need to be one specific system. And then sending us back the data that's required on a specific cadence so that once they utilize their system, they're able to extract their reports, give us the reporting accordingly. So overall, there's not a single documentation system that's being utilized. There's a variety.
Yes. And quickly, either of you, have you started to incorporate the glucose management indicator or the GMI from the CGM data in order to meet the A1C measure?
So this is a good question. I did touch on other measures. So those are really exploratory to scope further. Those are not included as of this current program. This program is really focused on some of our adherence measures.
Sure.
It is up for consideration though.
Nice. Thank you.
Yeah, so we have it was purely focused on adherence last year. We've forayed into some of the prescribing measures, specifically the SUPD measure as well as SPC. So we've started to expand the measure set. And I think the hemoglobin would be another nice feature to add.
Yeah. Great. I'm going to go ahead and just give you guys some PQA announcements. So thank you very much, Maaria and Jeff, for joining us. This has been really fascinating.
Thank you.
We're going to close today's webinar with a few announcements from me. Registration is open for our PQA convenes in the 2025 PQA Leadership Summit. Both of these will be held in Arlington, Virginia. PQA convenes will take place on Thursday, November 13th. We will bring leaders in artificial intelligence together to discuss the impact of AI on quality medication use. And then the Leadership Summit will follow that directly and take place on both November 13th as well as Friday, November 14th, with a focus on PQA's blueprint for 2030. We've sent registration information to the key contacts for each PQA member organization. If you have any questions, I've put our meetings at pqaalliance.org contact information into the chat. Additionally, please mark your calendars and come visit us here on Zoom for our next stakeholder advisory meeting. It's next week, Wednesday, August 13th at 1 p.m. Eastern. The last stakeholder meeting of 2025 will then happen on Wednesday, October 22nd at 1 p.m. Registration information is available to PQA members and will be on the Member Resources Library on our website. Last, also mark your calendars, September 18th, 1 p.m. is our PQA Measure Endorsement and Retirement meeting hosted by PQA staff. During this meeting, we'll discuss the measures being considered for endorsement as well as those being considered for retirement and address any questions received during the public comment period that has recently concluded. So members can find the registration link in the Member Resources Library. Thank you very much for being here. Thanks for joining us. Have a good rest of your day.